Hello, my name is Emma Ives, and I'm a second-year pharmacy student at UNC, currently on rotation at the Cone Health Family Medicine Center. Today, I'll be going over the latest pharmacy news for the month of January. For this month's news, we'll discuss the recent approvals for Wegovy in adolescents with obesity, Airsupra as rescue therapy, and Leqembi for Alzheimer's. We'll also discuss the Golden ADA updates for 2023, as well as the removal of the X waiver in prescribing buprenorphine. The first approval we'll discuss is the use of Wegovy in adolescents with obesity. Wegovy was approved for weight loss in adolescent patients with a BMI in the 95th percentile or higher as an adjunctive therapy. Dosing starts at 0.24 milligrams once weekly, titrated up every 4 weeks until 2.4 milligrams is reached. It comes in 0.25, 0.5, 1, 1.7, and 2.4 milligram autoinjectors. It was approved based on the results of the STEP-TEEN study. Wegovy, also called semaglutide, was initiated at 0.25 milligrams and titrated up every 4 weeks until the maintenance dose was reached, or the dose that did not cause any adverse side effects. The study saw clinically relevant decreases in BMI and body weight with semaglutide when compared to lifestyle intervention alone. Semaglutide also improved other BMI and weight-related measures, such as LDL and triglycerides, compared to placebo. Similar to the adult studies, the most common adverse effects were GI upset and abdominal pain. Wegovy carries a black box warning for patients who have a personal or family history of thyroid cancer. While rare, pancreatitis and gallbladder disease can occur. If suspected, it is best practice to discontinue Wegovy. Do not restart Wegovy in patients with confirmed pancreatitis or gallbladder disease. Wegovy is recommended for both obese adolescents and adults who have tried and failed other weight loss options, regardless if they have type 2 diabetes. It is to be used in conjunction with lifestyle modifications. The strength of these recommendations are an A based on the results of the STEP-TEENS trial. The next approval we'll discuss is Airsupra as a rescue therapy for those with asthma. Airsupra is a combination albuterol budesonide inhaler approved for patients 18 years and older with moderate to severe asthma. It is to be used as an as-needed therapy in addition to a patient's asthma maintenance medication to prevent severe exacerbations. It was approved based on the results of the Mandala study. The study looked at high-dose budesonide albuterol, low-dose budesonide albuterol, and albuterol alone as rescue therapy in addition to a patient's normal maintenance regimen. Children 4 to 11 years old were randomized to the low-dose combination or albuterol alone group due to concerns about high-dose inhaled corticosteroids. The study found the risk of severe asthma exacerbation to be significantly lower in the high-dose combination group than albuterol alone. The results of the low-dose combination group were not different from albuterol alone. The most common adverse effects associated with Airsupra therapy were nasopharyngitis, candidiasis, and dysphonia. Based on these adverse effects, patients should be counseled to rinse mouth after inhalation. The inhaler should be primed before first use, if it's been more than 7 days since last use, if it's been dropped, and after cleaning. Use caution in patients with cardiovascular disorders, convulsive disorders, and diabetes. If paradoxical bronchospasm should occur, patients should discontinue Airsupra therapy. Airsupra is meant to fill the gap as a rescue medication to reduce the risk of severe asthma exacerbation by addressing inflammation in patients with moderate to severe asthma. The strength of recommendation is a B based on the results of the study. Airsupra cannot be applicable to patients 4 to 11 years old as they were not included in the high-dose combination group. In addition, the study did not have very many participants under the age of 18. More data is needed to confirm if Airsupra is safe and effective in those groups at the FDA-approved dosage. Final FDA approval we'll discuss is Leqembi, which has been approved for those with Alzheimer's disease. Leqembi, or lecanemab, was approved via the accelerated approval pathway for the treatment of Alzheimer's patients with mild cognitive impairment. It is the second drug in this new Alzheimer class, the first being the controversial drug Aduhelm. It is administered intravenously every 2 weeks. Clarity AD served as the confirmatory trial for the approval of Leqembi. It was a Phase 3 randomized controlled trial that compared lecanemab to placebo over the course of 18 months. After 18 months of treatment, patients were assessed via the CDR-SB measure and compared to their baseline result. Patients' mean scores for both placebo and lecanemab were increased at the end of 18 months, meaning increased impairment. However, the main change in baseline was smaller in the lecanemab group. Secondary endpoints also showed less disease progression in the lecanemab group when compared to placebo. The main adverse effects seen in the Clarity AD study were infusion-related reactions and amyloid-related imaging abnormalities. While this was numerically lower than previous trials, due to trial design and methods, direct comparisons cannot be drawn. The strength of recommendations is a C based on the outcomes data. More studies are needed to verify safety and efficacy. The key takeaways for the following FDA approvals are listed here. Wegovy has been approved as an adjunctive therapy for patients who have tried and failed other options. Airsupra has been approved to fill the gap in inflammation-reducing therapies for patients who have moderate to severe asthma, but needs more safety data to confirm efficacy. While Leqembi saw lower instances of ARIA than previous trials, it requires more studies to confirm safety endpoints. We will now discuss the most pertinent changes to the new 2023 GOLD guidelines. The first update is the revised definition of COPD. COPD is characterized by a variety of respiratory symptoms, including dyspnea, cough, sputum production, and exacerbations. Heterogeneous has been added to the definition to reflect the variety of symptoms and presentations of the disease. The new GOLD update continued to use GOLD categories 1 through 4, which were based on the patient's FEV1. The biggest change is the new assessment tool. Category C and D have been eliminated and replaced with E for exacerbation. This changes first-line treatment options shown on the next slide. Previously, LAMA was indicated for Group C, and LAMA, LAMA plus LABA, or ICS plus LABA were indicated for Group D. Now, LABA-LAMA is indicated for Groups B and E. Triple therapy is considered if blood eosinophils are greater than 300 or reversibility indicative of COPD and asthma overlap is demonstrated in spirometry. In terms of follow-up management, if treatment is not appropriate for the patient, check adherence and inhaler technique first and foremost. If both dyspnea and exacerbations need to be treated, follow the exacerbation pathway on the right when escalating therapy. Clinically, we recognize LABA monotherapy, listed on both the left and right sides of the slide, is not used. In terms of bronchodilators in COPD, combination LABA-LAMA therapy greatly reduces symptoms and exacerbations compared to monotherapy. LABA-ICS therapy is not encouraged in COPD. Triple therapy has been shown to be superior and is the preferred choice if ICS is indicated. It has also been shown that a single inhaler therapy is preferred over multiple inhaler therapy in terms of ease of use for the patient. ICS initiation has not changed in the 2023 guidelines. It is favored if the patient has a history of hospitalizations for exacerbations, blood eosinophils greater than 300, or a history of asthma. ICS should be discontinued if pneumonia occurs or blood eosinophils are less than 100. The new COPD guidelines updated the definition of exacerbation to include a time frame for symptoms of less than 14 days. The strength of the new 2023 GOLD guidelines is an A. They should be utilized to optimize care for patients with COPD. We will now discuss the most pertinent changes to the 2023 ADA guidelines. A1C testing is encouraged for diabetes screening and diagnosis, so appropriate therapy changes can be addressed in the same appointment. FIB-4 screening for non-alcoholic fatty liver disease is also encouraged for diabetes patients with obesity, CKD, or are older in age. A new addition to the guidelines is the recommendation of pioglitazone for reducing stroke or MI in people with a history of stroke, evidence of insulin resistance, and pre-diabetes. The addition of pioglitazone for cardiovascular prevention is based on the IRIS study from 2016. At 4.8 years, the risk of stroke or MI as well as diabetes was lower in the pioglitazone group with a number needed to treat of 36. However, the risks of weight gain, edema, and fracture were higher in patients treated with pioglitazone. While lower doses may mitigate adverse effects, more studies are needed to confirm benefit. Another addition to the 2023 guidelines was the consideration of social determinants of health to guide treatment recommendations. The guidelines recommended screening for the hunger vital sign to screen patients for food insecurity. The guidelines also saw a greater emphasis on larger weight losses based on efficacy and access to new medications like Mounjaro, Wegovy, and Ozempic. The ADA definition of hypertension now aligns with the accepted ACC/AHA definition of greater than 130/80. The blood pressure goal for diabetes patients is now less than 130/80. Based on recent data, SGLT2 inhibitors have an even greater role in diabetes and CKD. SGLT2 inhibitors are a pillar of heart failure regardless of the patient's diabetes status. Finerenone has also been indicated in diabetes and CKD with albuminuria in addition to ACEs and ARBs. The 2023 ADA guidelines now have a new LDL goal of less than 70 for diabetes patients. Patients with diabetes and established ASCVD have an LDL goal of less than 55. Options for diabetes treatment now take into consideration comorbid conditions such as ASCVD, heart failure, and CKD, in addition to patient glycemic or weight management goals. If the patient goal is cardiorenal risk reduction in high-risk patients, SGLT2 inhibitors and GLP-1s are first-line options. If the goal is glycemic control, our first-line choices for patients are Trulicity, Mounjaro, or insulin. If weight management is the goal, our first-line choices are Ozempic and Mounjaro. The strength of the new 2023 ADA guidelines is in A. They should be utilized to optimize care for patients with diabetes and other comorbid conditions. The last update we'll discuss is the Mainstreaming Addiction Treatment Act, which went into effect on January 1st of this year. The MAT Act removes the data waiver for prescribers of buprenorphine. Prescribers no longer have a cap on how many patients they can prescribe to, and they do not need to register for a DEA waiver to prescribe. Now, all prescriptions for buprenorphine will only require a standard DEA registration number. There are new training requirements for prescribers. The reason this is important is 11% of people have access to buprenorphine treatment. Removing the cap on patients for prescribers will allow them to treat more patients and reduce the stigma surrounding treatment. As prescribers no longer need to register to prescribe buprenorphine, this will improve access to rural and marginalized communities. The key takeaways from the MAT Act are that it is easier to prescribe buprenorphine to patients than previously, which will improve access for historically underserved communities. To review, we discussed the recent approvals for Wegovy in adolescents with obesity, Airsupra as rescue therapy, and Leqembi for Alzheimer's. We also discussed the GOLD and ADA updates for 2023, as well as the removal of the X waiver in prescribing buprenorphine. Special thanks to Dr. Koval and Madison Yates for contributions to this month's updates. Thanks for listening to this month's news you can use.